Okay, well, welcome everyone. We are very excited for tonight's conversation. Not only is it important, we have an amazing group of people for you to interact with here. Just expertise from all over the board. So we're really excited about that. I just want to give you a couple of housekeeping notes. One is that we are recording this session and it is streaming live on Facebook. So we will be preparing that video for you tomorrow. If at any point you want to review or you want to share, we'll send a link tomorrow for you to do that. Additionally, if you have questions, because Cosmetic Surgery Forum is incredibly interactive, we have a couple of options for you to engage. The first one is at the bottom of your screen. There is a chat function. And within that chat function, you can, Patricia Walker's already in it. Good job. You can address a question to the panelists and attendees, or to a specific panelist if you're interested. So please feel free to use that function as we go through the session. Additionally, there is a Q&A function at the bottom of your screen that you can address questions as well. We will be looking to that for questions to add to the end of our session for the Q&A. And so feel free to place those there. And if throughout there is something burning that you need to say, you can hit your raise hand button over there, and we'll do our best to get to you. Obviously, we have actually 300 people participating today in addition to our panelists. So obviously we won't get to everyone, but we will absolutely do our best to address everything we need to. So I'll turn it back over to you. Thank you.
Thank you so much. Well, I first want to go around our panel and have everybody introduce themselves. So Dr. Siri Knutsen-Larson, please.
My name is Siri Knutsen-Larson. I practice medical and surgical dermatology in Rapid City, South Dakota at Monument Health.
Thank you. And Doris?
I'm Doris Day. I'm a dermatologist in New York. I've been in practice for 22 years.
Great. Adam Jackson?
Yeah, hi, my name's Adam Jackson. I'm a clinical pharmacy specialist for the past 20 years in infectious diseases and now in drug utilization management with Kaiser Permanente here in Denver, Colorado.
Michael?
I'm Michael Gold. I'm a dermatologist in Nashville, Tennessee, the home of Cosmetic Surgery Forum, and glad to have them with us. And I've been in practice well over 30 years now, so I'm glad to be part of this.
And if you ever need to know anything, Michael knows the answer. So that's why he's on this, among other reasons. Steve Comite?
Hi, everybody. My name is Steve Comite. I'm in private practice in Midtown, New York City. I've been doing so, like Michael, for a bit over 30 years. I'm an associate professor in the Department of Dermatology at Mount Sinai. Thanks for having me on.
Thank you. Steve Dayan?
Hi, I'm Steve Dayan. I'm a facial plastic surgeon from Chicago and a perennially attendee and faculty member at Cosmetic Surgery Forum.
Thank you. Joel?
Joel Cohen. I'm from Denver, Colorado. I've enjoyed speaking at Cosmetic Surgery Forum for many years, and I'm grateful that Joel Schlessinger has put together this great program. I'm from Denver, which is not the home of anything, but I grew up in Detroit, which is the home of rock and roll.
Very good. And then Renier?
Hello, I'm Renier van Aardt. Thank you for inviting me. I'm a cosmetic physician practicing aesthetic medicine in Halifax, Nova Scotia. I've been in practice here doing aesthetic medicine for 20 years.
Thank you. And then Sabrina.
Hello, my name is Sabrina Fabi. I'm a dermatologist practicing in San Diego, California for the last 10 years and have been blessed to be able to join Cosmetic Surgery Forum many times over the last couple of years. Thank you for having me.
We feel the same way exactly. And then Natasha, if you can introduce yourself and Meg and explain what you're going to be doing.
Here I am with my headphones on, looking very techy. I actually work with Dr. Schlessinger in our clinic and Cosmetic Surgery Forum. I'm the event coordinator, so I'm the one you see running around like a very cool duck underwater kind of situation. And I work very closely with Meg, who's here as well.
Hi, everyone. I'm Meg. I work closely with Natasha and also help assist Dr. Schlessinger and Nancy at Cosmetic Surgery Forum. So thank you all for joining us tonight.
Yes,
Thank
we
you.
really appreciate it. So if you haven't need anything, you are welcome to message us on the side. Thanks.
Well, so now that we have the introductions, I think, Natasha, can you put the first picture up? I think that's probably the where the meat of the matter is. And thank you. So we have, the reason we started this, or that I came up with this idea, was that I felt it was really important that we have some discussion of this question of what is going on with fillers and vaccines and what happens. So this is Renier's case, correct?
That is correct, yes.
Can you describe it or explain what happened here?
Yes, certainly. This happened this past Wednesday. This patient is a 35-year-old lady. She's a paramedic, and she received the second dose of the Pfizer vaccine 3 weeks after the first dose. And within 6 hours of receiving the vaccine, it was actually 4.5 hours after that she started noticing swelling. And this photograph is at the time that she sent me a text and the swelling of her lips. And she connected it with the filler treatment she had received in July of this year. She took an antihistamine and ibuprofen at home. That was her own thinking to do that. Within 2 hours, actually, it had worsened. So if you want to bring up the next photo, this was the 2 hours later, yep. And she decided at that point to head over to the ER. She actually works in the hospital and is well connected there. So she lives close by. She headed right over, and they administered dexamethasone for her, observed her for a couple of hours. Things started improving, and within 24 hours, the swelling started to subside, and by 48 hours later, it was completely back to baseline.
Within 48 hours, thank you.
Yes, so this photograph is 24 hours after the last photo you saw.
And remind us, what was the product that she had used?
So she's had 3 treatments in the past. In December of 2016, she received Juvederm Ultra for lip filler. Then a year after, in December 2017, she had received a Vicross product. It was Volift for lip treatment. And in July of this year, she received a Bellatero product. It was Soft for top-up.
Great, thank you so much. And she remains clear right now?
Yes, she remains clear. Yeah, she's
Great,
fine.
great. Any other systemic symptoms that she experienced that you know of?
Fortunately, nothing else. At no point was she short of breath or had any other concerning symptoms. She just felt that she wanted to avert potential further symptoms by going to the hospital, and they gave her dexamethasone out of an abundance of caution, and it cleared up pretty quickly after that.
Great. And I'm going to go on to Siri next. If you can present your case, that'd be great. Thank you.
So I received the Moderna vaccine last Monday at about 8:30 Mountain Standard Time. Felt fine all day, went to bed that night, woke up in the middle of the night with severe chills and subjective fever, and finally took my temp around 5 a.m. and had a temp of 102. So employee health made me stay home. And I noticed throughout the day that my right tear trough was painful, and I didn't think much of it. But then I got up to go to the bathroom around 3, and my lips were asymmetrically swollen. By the time I went to bed that night, my right tear trough was pretty swollen. And then I think most of you have seen the picture that I posted initially on the Facebook group when I woke up the next morning and frankly scared my husband. Throughout that day, I then posted that picture and I got in touch with Gilly Munavale, and he recommended starting lisinopril just based on his theory. And actually my swelling got much worse than that. And those photos will actually be published in the JAMA paper. I had taken 10 milligrams of Zyrtec that morning and didn't take any further antihistamines following that, but I started the lisinopril around between 9 and 11 a.m. Mountain Standard Time. I felt throughout the day as I was operating that my left tear trough was also swelling pretty rapidly. but then came home and I did exercise, but it pretty abruptly arrested around 3 to 4 p.m. The swelling itself, I took no other further antihistamines. I continued on 5 milligrams of lisinopril throughout the next couple of days. I would say that my face was completely back to normal by Saturday, but was still pretty noticeably swollen on Friday.
And your injections were again when? Thursday?
Injections, my filler injections.
Right. No, I'm sorry, the Moderna injection.
Moderna was Monday.
Oh.
And the picture that's everyone has seen was on Wednesday morning.
Gotcha. Okay. Well, thank you so much. And how are you feeling now?
I feel fine, like nothing ever happened.
Can I ask a quick question, Siri? When was the filler injected?
It was November of 2019. I had Juvederm Ultra in my lips and Voluma in my tear troughs.
Great, thanks.
Thank you so much.
Steroids, right, Siri?
What was that?
You weren't given steroids?
No, I was trying to avoid them because I didn't want to blunt a seroconversion response of the vaccine.
That is a question that we probably want to address on the conference here, because there is a bit of discussion over that right now. But thank you so much. And then Steve Comite.
Yeah, thanks, Joel, for setting up the seminar on such short notice. And to you, Natasha and Meg, for all you all do. It's an honor to be presenting here among such an amazing group of panelists, whom I personally enjoy watching and learning from all of your content. I received this information from a fellow dermatologist in New York City. The patient was a 45-year-old female physician assistant who has had fillers in the past. The patient was injected with Juvederm Ultra Plus in mid-November, 1 syringe, cheeks, marionettes, and anal folds. It was a touch-up. She subsequently had the Moderna vaccine about 6 weeks later at the end of December. The patient was in an early cohort to receive the vaccine because she works at a hospital. Within a few hours, she developed pain, but unlike what we've seen before, very little swelling in all of the areas that were treated with fillers. She did not contact the dermatologist on her own. She is a PA. She took oral antihistamines, Zyrtec right away, and Benadryl at night for 2 days, and the pain and very mild swelling resolved. She called the dermatologist a few days later, so no photos are available, both to report it as well as her concerns about the second dose of vaccine, which is coming up relatively soon. So this is another case bringing evidence that the Moderna vaccine and the filler interaction is real, as we've seen. But in this case, the side effects were mild and not disfiguring.
Thank you so much. Well, I think it's really quite interesting that we are seeing these. And Renier, your vaccine, that your patient, she had Moderna also?
She had the Pfizer vaccine, and this was after the second dose of the vaccine.
Okay, gotcha.
Which were about 3 weeks apart.
Gotcha. Well, thank you so much. This is incredibly helpful. So I guess the question that comes in is what panelists feel should be done if this happens to you or one of your patients. So I'll start with Michael, if you don't mind.
Sure. So, I feel for everybody feel for you, and sorry that it happened and your patients. I have not seen this. We are making sure that we are telling our patients now that this has been reported. We've actually added a paragraph to our consent form about vaccines, thanks to what we learned from Adam in another call last week. And just that it is unfortunate that Renier's case was the first time I'm hearing about Pfizer, but I'm sure it's been out there already. We know there's been some cases with Moderna. And the reality is, and I think that the ASDS and the plastic surgical groups have all stated, the risk of having this is extremely rare with the number of fillers. However, again, I'm looking more at Siri right now. It's real. And when it's real and it's it's an issue. And I think we all have to address it with our patients about, the fact that this has happened, it's been reported. But I think the silver lining at the end of this is that it's treatable with antihistamines and or steroids, very simply, very quickly. And every case that we know of is resolved. The 3 in the studies in all these cases within 24 to 48 hours. But I do think it's imperative now that we tell our patients, and again, I think part of this discussion is for the patients that are wanting fillers and wanting the vaccine, what do we tell them moving forward? But I would caution everybody, do not let this stop you from getting a vaccine.
Absolutely. And Adam Jackson, I wonder if you could say a few words about your feelings on steroids and the vaccine and risk of using steroids.
Right. The reality is that the immunosuppression seen from steroids is dependent upon a few factors: dose, duration, and route. And the reality is, for the vast majority of these cases, if a person receives steroids, I would assume that it would be a short course sort of burst phenomenon, like you might see with a Medrol dose pack, or you might see for an asthma exacerbation or something of that sort. Those sorts of doses and duration actually really should not have any true or comprehensive blunting effect of the immunogenicity. Any reduction that you would see, I would suspect, would be very short-lived, and I would doubt strongly that it would have any long-term immunogenicity problems associated with it.
Thank you so much. And I think that there has been a variety of opinion on the question of steroids. One of our attendees, Dr. Dragan, had asked what the dose, Larissa Dragan had asked what the dose of steroid was that the patient was given. When you, I believe it was
Rennie's case.
There.
Rennie.
I apologize. I'm not sure about the dosage that the patient received.
Okay. I think that, if it were me, I would probably just do a Medrol dose pack and see how that went.
No, can I make a comment on that? Because I think Siri is important, because her case resolved without any steroids. And of the cases that were reported by Moderna, they weren't given steroids. And there's some evidence that steroids might blunt the response that I think Siri mentioned. So all of them are resolving, and whether with mild, with antihistamines, perhaps lisinopril, or you said a diuretic, which I didn't really consider. But maybe steroids is not the way to go. Maybe to avoid steroids and see if we can get this resolved on its own and not affect or reduce or blunt the immune response.
I would.
Gilly's thinking was that there may be ACE receptors around quiescent filler, and that when you have the vaccine and you have that spike protein, that's going to lead to further activation. And so lisinopril, which is an ACE inhibitor, might make that go away. And I think that's what Siri was aiming for, right, Siri, in her treatment. And it seemed to have helped her. And I think, Siri, you said you only took it for 5 days.
Yes, I started it on Wednesday and I stopped it Sunday.
And a complete baseline. I think also something that's interesting is the pain associated with this. I think that's something that needs to also be documented, and also keep track of what fillers were injected. So I think part of the problem is that many people have had different fillers. So they've had a combination of Vicross, Nasha, and now the newer fillers available. And if they're not from this country, maybe even a broader array. But it's really sort of collecting this data, and it seems to be trending more towards the Vicross fillers that seem to be more activated, that I keep hearing stories about. So I wonder if there really is something to the way the fillers are cross-linked that might have an impact.
If I can say subjectively, I had the Vicross under my tear troughs, obviously, and I felt like that response was much more robust than my lips. Just totally subjectively, so.
There's a great question that somebody just asked. Somebody just asked about who's collecting, and Adam, you may know, who's collecting the data, and to whom should we report reactions? Because again, there's 3 that were reported, and obviously there's a lot more. And how do we go about it, and what do we do?
Right. So I think a couple things. First, I want to go back just for a moment on the issue of steroids or not steroids. I'm always reminded of first rule: do no harm. And even though a short course of steroids probably won't be harmful, they can nonetheless have some untoward effects. So certainly, if steroids are not not essential, and I think that there's some judgment as to whether or not in a particular patient, depending upon the presentation. If they're not deemed essential, then avoidance would be probably the better course. In terms of reporting of adverse reactions, so there's two things. First of all, CDC rolled out something called vSafe, which when you get your first dose, everyone who's administering it, there's a QR code you should be able to scan with your phone. You put in just your name and your date, that you received it. And it's a pretty sweet system where they just keep on texting you and asking you for your responses to questions around adverse reactions. And you have a free text in there as well. The second thing is that the VAERS system, VAERS, and you can go to the CDC, if you just type in CDC VAERS, that's for Vaccine Adverse Event Reporting System. It doesn't have to be the healthcare professional who's overseeing the patient, it can be the patient themselves can report it. And so either of those two mechanisms, I think are a good method of reporting those reactions.
Thank you. And can you explain the immunogenicity of the two vaccines, Adam?
Yeah, so I think one of the really important things to note here, had there never been, admittedly I'm not a dermal filler expert, but had there never been a reported case of dermal filler reactions following things like either viral infections or immunizations, then I would view this as remarkable and quite interesting. However, the fact that it's been reported previously for vaccines like influenza that are not nearly as immunogenic or reactogenic as these vaccines really make me think, of course, this is simply just, for lack of a better phrase, I hate to say it, dumb bad luck, which is terrible to say to patients, and I certainly wouldn't say it to a patient. But there is some idiopathic notion to it. And so in terms of immunogenicity, these two vaccines are highly immunogenic and unfortunately highly reactogenic. And that, I just think this is just associated with that. I don't think it's, and I would not say that there'd be any difference between the two. I think if there is a difference, you'd have to have a huge sample size to find it. So I would just expect it with either.
Fantastic. Thank you. And how about the ACE inhibitor? There's one question on why we would anticipate ACE inhibitors would work.
So, the thing is that the spike protein binds to the ACE2 receptor, which is found throughout your body. The lisinopril, however, is an inhibitor of the angiotensin converting enzyme and not necessarily an actual antagonist at that, towards that receptor. And so I personally, if I had a patient who came in and we felt like we needed to do something, or if if I knew someone personally, I would aim much more towards probably not the antihistamines, although it's not going to hurt, but unless there's actual some sort of itch occurring, it's probably not histaminergic. Non-steroidals, or depending upon the severity, perhaps a Medrol or prednisone sort of dose pack thing. But I don't mechanistically, I don't see a clear enough connection there that I would. As a matter of fact, just when Siri, when I saw that picture and you mentioned lisinopril, the first thing I actually thought of, but I'm a pharmacy person, is angioedema due to ACE inhibitors. And I thought, no, wait a second, she's not talking about that. So I would not mechanistically connect that.
But I think it's a really important comment what Siri just posted up on the thing. You want to tell them what you wrote, Siri, for those who don't see the chat?
Someone asked if I would get the second dose, and I said I'd rather have that reaction than COVID personally, so I will do it without hesitation. I'm just going to take a couple days off afterwards.
100%. Now, there have been people who have been refused to have a second dose if they had some reactions, such as difficulty, with potential breathing issues or swelling of their face and elsewhere. So I guess to the group, do you feel where do you feel the point is where you would say, I don't think you should have dose 2? So I'll start with maybe Adam.
I'm going to venture a point here. I would not view any of the things we've discussed thus far as being a contraindication in the least. I would need to hear a reaction. Now, if a person said, listen, I'm not going through it again, I don't want to take the chance, that's obviously their personal choice. I'm not going down that road. But I need to hear a clear reaction in terms of time related. As a allergist friend of mine said, there is a reason why it's called an immediate type hypersensitivity reaction. I would need to hear within 30 minutes something resembling anaphylaxis, some clear and systemic signs of it. Localized reactogenicity like this, I would not view it all as a contraindication to the second dose.
Joel, let's ask the question to the group and to Steve also is, if somebody comes in and they know they're getting the vaccine in a few days or in a few weeks, would you tell them to hold off on getting fillers till after? And if you would, how long after would you say to hold off on fillers?
I think since obviously this is something that can be delayed, the dermal filler can be delayed. And nowadays, if you can get a shot, go and get it. So I would say if you wanted to, certainly by 2 to 3 weeks after a dose, probably 2 weeks, you would think that all of that sort of revving up, for lack of a better phrase, has occurred. Of course, keep in mind, there are 2 doses involved. And so you'd probably want to wait until after the second dose, because it could happen either way. If anything, second dose might be more likely than the first, since we know that reactogenicity is more common after the second dose with both of these mRNA vaccines.
And then there was a question. Oh, sorry, what?
Sorry, Joel, we actually sent out an e-blast to all of our database, not discouraging people to, they should continue and get their vaccine, but that if they have their vaccine scheduled, that they should wait at least 2 weeks before the vaccination or 2 weeks after their last vaccination before they come in for their dermal fillers.
And that's what we do, for example, if somebody's planning on having dental surgery, a root canal, a planned root canal, we always encourage them to hold off. So that's excellent. One attendee, Deborah Mangione, asked, has anyone seen filler swelling after COVID itself? Filler swelling after COVID, not the vaccine. Any people who are on this call of the participants that had that, please let us know, because that would be interesting to know.
Can I make a comment that's going to be a little bit controversial, perhaps, but something to think about. I agree with all of you on everything we've said so far about the vaccine, about delaying it 2 weeks, fillers perhaps 2 weeks around there. But I've had enough people come to me who are saying, should I not get the vaccine? And I'm like, pro-vaccine, I think you should get it. I've had 2 doses of it, and I'm a very big fan of it. However, for those who come in who are adamant against it, which is a lot of people, a lot more than we may be recognizing, I think they have an argument. And I think it's fair, their argument. I think we should be open and honest and listen to their argument. The data on the vaccine is fantastic and it's robust, but it's not complete. And for any of us to say it's complete, we're not being fair to science or to ourselves. We don't know a lot of things. I read through both EUA reports. It's on the FDA website. They're each about 70 pages. I read through it in detail, both of them. And I'm a scientist like all of you are here. Many of us are researchers here. And knowing, as a researcher, you look at this, you're like, it's good, but there's a lot still that hasn't been answered. There's 180 people who dropped out of the Pfizer study, 120 people who dropped out of the Moderna study. Why did they drop out? 80 people were lost to follow-up. If 1 or 2 or 3 of those people came back positive, it completely changes the numbers of people who may have been positive after getting the vaccine. So and we had 2-month follow-up. That's not a lot of follow-up. There's this concept of antibody enhancement. Listen, I think it's unlikely. And I read through the report, it was well done science, it's robust, but I understand people being cautious, people who've had positive SARS-CoV-2, should they get vaccinated? And we're pushing them. Pregnant women, we're treating pregnant women, but we don't have good data on whether or not pregnant people should be getting it. So those who are resistant to it, I listen to them, I understand them, and I don't shame them into getting it if they don't want to get it. Having said that, I'm very much pro-vaccine. My family's getting it, I got it, and I want all my loved ones to get it, but they have an argument. We have to be open to it.
I want to echo what you're saying, because vaccine hesitancy, especially for something like this, is real and entirely understandable. And the way I phrase it to everyone on my blog and elsewhere is, if I want as many people to get vaccinated as possible, which I do for everything under the sun, then I need people to get vaccinated when they are comfortable getting vaccinated. Any untoward pushing will only serve to alienate and harden people's responses, and that's not the way to go. So I think that's an important point. You know, it's like, if you're comfortable, I'll give you the information. I hope you choose, but this is your choice. You should be comfortable with it.
I agree. That's what I told my staff in my office, and they all wanted the vaccine, which is great. But this is not FDA approved, these vaccines. They're emergency authorization. So it's completely different. I mean, I think that if you're older and you have comorbidities, the vaccine is definitely better than COVID. But if you're a young, healthy woman of childbearing years where your risk of something bad happening from COVID is negligible, then having a question is not unreasonable. So I really think that it's always good to question. And one of the things that's been disappointing is that when I or others, and you, Steve, have brought up questions about the vaccine and its safety, you're almost shamed as a physician and as a scientist about asking questions, which science should never do. So for anybody who's watching who has questions, I think it's really healthy to have these robust discussions, to always question the science, and to do what Steve did and look through the data before judging someone else about having questions. I looked at it also, and I found that same information. And a lot of people will just roll their eyes and say, you know what, it's better than COVID. I'm like, well, is it for everybody?
So in terms of actual data from the FDA trial for Moderna, if you look specifically at local reactogenicity, which is arm redness, swelling, pain at that site, maybe lymphadenopathy, or systemic reactogenicity, which is headaches, flu-like malaise, it seems that from the study overall, people on their second injection had a lot more of that. And the younger people had more of a tendency to more reactogenicity, whether it was local or systemic. Unfortunately, when they made groups, the younger people was 18 to 64, so we don't have a split of that data, and the older people was older than 65. I haven't seen anything to correlate that those 2 or possibly 3 patients, if you include the lip that may have been angioedema, were patients that had any other level of reactogenicity. So I think that, you know, we do need to think about this, but those symptoms of reactogenicity, whether they were local or systemic, they seem to last 5 to 7 days. In fact, most of them were gone by 5 days. So I think, you know, when we say wait about 2 weeks, I think that makes a lot of sense. 2 or 2+ weeks really does make sense. And then if we look to other experiences, you know, we have had patients who've had dental procedures. It's been well reported in the literature, and they have facial swelling where fillers may have occurred. We don't tell people not to avoid, you know, to avoid dental procedures. It's just something that we understand, and there's quite a bit of data on that that gets reported to the MAUDE database. There's other situations. I saw a patient who had the shingles vaccine and within a week ended up had facial swelling. I was not their injecting physician, but I was their treating physician. And I don't know what filler specifically they had, but there's a lot of barriers to reporting things to MAUDE. But I have seen a patient who had shingles vaccine who within a week had facial filler lighting up. So we've seen these situations before. They are treatable. Usually they go away on their own, and data is not the plural of anecdote, but you know, it can happen with other vaccines such as shingles, and other people have reported it with pneumococcal vaccine as well.
And just to comment on what Joel said, sorry, Doris, the one person who had that lip swelling, Joel, in the trial also had reported it after the flu vaccine. So we do see it after vaccines. That one particular subject of 3 could have just had a reaction to something that's in the vaccines, like the many preservatives that are in the vaccine. So we don't know what it may be. And I do have a question for all of you, because I think that maybe others might be thinking it. Somebody asked about hyaluronidase. should we be injecting hyaluronidase? And so I think for me, for now, I'd feel safe just putting them on an antihistamine. If you look at the Moderna report, most of the 2 panfacial swelling cases resolved within 2 to 3 days. And I think I feel comfortable just with an antihistamine. I probably would not do a steroid, but maybe the rest of the panel can offer their insight of what they would do in their clinical setting.
And I think that Siri, did you consider doing hyaluronidase on yourself?
I did not. I just decided to wait a couple of days and it was done. So I didn't want to go through hyaluronidase if I didn't have to.
Personally, I don't think I would. Doris?
No, I wouldn't. I think it's good to know that we have it in case we need it if it doesn't resolve with these other measures. I would start with the antihistamines, and then before the next vaccine, maybe consider antihistamines even before the vaccine, so you sort of have the blood levels. Because once you take the antihistamines, you're trying to chase a reaction. So the next time around, if you're prone to it, just start it early. And then hyaluronidase if it doesn't resolve after a week or so of the antihistamines and Medbrol.
And Adam, since we're on you right now, are there any contraindications to using antihistamines or non-steroidal anti-inflammatory drugs peri-vaccination, i.e. that they might reduce the efficacy?
No, not at all. There's a handful of various, certainly not for antihistamines, and the available data looking at antipyretics, whether it's acetaminophen or NSAIDs around vaccinations, shows variable at most effect on immunogenicity and nothing long-term. So I'm not saying I would use them necessarily prophylactically. I think that's a personal choice, but if someone said, gosh, I just got lots of muscle aches, I really want to take some ibuprofen, I would say, okay, go ahead. I would not have concerns about the
I want to disagree with Adam on that a little bit. I'm not a pharmacist, nor am I an expert in vaccines, but I've been doing a lot of research, and I pulled up a meta-analysis this week, and I sent it to some of you on the panel looking at antipyretics, and there was mixed results on antipyretics, whether or not it can blunt responses. Most of the studies that they reported in which it did blunt the response, which were randomized in clinical controlled trials, were in children when it was given prophylactically. And it was usually ibuprofen was worse than the acetaminophen. So I will tell you that this Friday and Saturday, I was in bed all day long and massive migraines, and I wouldn't take the ibuprofen because I didn't want to blunt the response. I let my fever run. And there's also evidence that if you let a fever run with COVID, that you get a better immune response and you may resolve better. You may have less severe symptoms. So I'm a fan of letting the fever run and not using antipyretics if you can get away with it, and waiting at least 4 to 24 hours after you get the vaccine. So I respect Adam's position. There's just other people out there who say it differently, and I think we should know that.
I mean, certainly that's a reasonable position, and I wouldn't necessarily say take it prophylactically. So we can. Yeah. We've had a long, drawn-out discussion about that meta-analysis because I know of that one, but it's okay.
So I want to put.
Yeah, maybe it's not so good. Yeah.
I want to put Adam on the spot too for a second, because he and I have been talking we've been doing our own emailing back and forth. And again, Steve, I agree with everything you said to a point. I think that for those that know me, I come from a family that makes vaccines for a living, so I'm very pro-vaccine. That. My understanding is within the first 42 days, we get most every bit of our adverse reaction profile. So again, 30,000 patients studied in each study, if that's the number. Yeah, we don't have everything. We're not going to have everything for 2 years. I get that. But we know most. And again, Adam, I would love for you to comment on this, because again, I have employees in my office that say we don't know what it's going on, and we're going to wait. And I wrestle with the fact that I want my whole staff vaccinated. What do we do with that? But I do think that we know a lot, and we don't know everything. But again, these are local reactions that we're talking about on the arms, on the the more systemic ones are more of an issue, but they go away. We know that people get it. We sort of know, I think, the percentages now that are associated with those. And yeah, I mean, you don't want to be the person with it. But can you comment, Adam? And I'll shut up.
I think you raise a good point. So we certainly know a lot. And there are two things together that we need to think about. One is numbers of doses, and one is length of time of follow-up. So first of all, in terms of numbers of doses, the phrase I heard from Paul Offit, who's a big vaccinologist in Philadelphia, and I've heard it from several others, so I'm sure there was some original vaccinologist 100 years who said this 100 years ago, is I will breathe a sigh of relief when there are 3 million doses. And what I would add on to that is I will breathe a sigh of relief when we have data on 42 weeks after for at least 3 million doses. And there are and here are the two reasons for that. First of all, 42 days, the basis of it is a broad consensus among the vaccines we have available. And it's of such solidness, it's actually incorporated into the Vaccine Injury Compensation and Protection Act. The longest furthest out you see for like things like Guillain-Barré with influenza vaccine, which has only been linked with one of them really, is 42 weeks. And there's a lot of immunologically reasons why that would be the case. So it's not, the clinical trials gave us a lot. When you look at the number of people who've been vaccinated, and we're about, I think, 4 weeks into Pfizer's EUA use, I think 3 weeks into Moderna's. So we got this rolling time frame going on. By the end of January, certainly by the end of February, we are going to have 6 weeks follow-up or more on millions of doses, not just here, but also in the UK and in other places. And so I think we will, quicker than any other vaccine we know of, we will have sufficient data to feel, you know, I never say anything's 100%, but we're gonna have enough data to really feel comfortable hanging our hat on.
So Adam, sometimes when we're treating what is a biofilm, which is obviously very different than this, but when we suspect a biofilm, somebody may have an infection, it tends to be red, it tends to be indurated and fluctuant. We employ the use of colchicine, and you know, it's a simple to dose, it's 0.6 milligrams. You can do it once or twice a day. Has anybody incorporated colchicine to treat these post-vaccine swelling? Is there any concern about colchicine in terms of this, or is that non-specific enough that that may be helpful?
Right. In just a moment, I just saw someone typed up 42 weeks or 42 days. It is 42 days. So 6 weeks, 42 days. That's the time frame. Colchicine. I have not heard of using it from a pharmacy perspective. I view colchicine as having one particular use, and even then, in a very, very, very small minority of patients, which is gout. Colchicine is not something I would pull out for this at all.
So for delayed inflammatory reactions from fillers, it's been part of different algorithms that many of us have co-authored these algorithms. And when nothing seems to be sort of working, and it may be the fact that it's sort of thrown on later, but many of us have had a good experience using that. Claudio Di Lorenzi in Canada uses it quite a bit for these delayed inflammatory reactions as well. So I think, you know, if there is concern about antipyretics, if there's concern for one reason or another about systemic steroids, you know, and people have tried lisinopril, then you know, it may be a medication without significant risk that could be tried.
As long as they take it with food. And this is a great example of the different perspectives on different drugs. Because from my background, I'm immediately thinking of the adverse events of colchicine.
And then regarding your background, you know, I've read quite a bit about the MMR vaccine being something that's been somewhat protective. And there's a lot of postulation, including the microbiology literature, that one of the reasons kids don't seem to be uniformly affected the way that adults are, and this can be quite variable and usually much milder in kids, is the fact that they are typically have an antibody threshold to the MMR vaccine. So can you comment, or has other people actually seen this out there? Because I think the data looks pretty intriguing. I'm married to a pediatrician and we've discussed this quite a bit.
Right. Well, first, I think I just hope that Michael's dog is vaccinated. I think that that's very important.
I'm vaccinated.
Second of all, so there is certainly evidence that indicates an indirect immunological effect from live vaccines in general. It's been seen with BCG, it's been seen with MMR, across a whole host of various different things. And that has certainly gotten a grip on the collective imagination around how we might be able to employ other things. And maybe this explains the pediatric thing. Maybe it explains lower rates here or whatever. Is it possible that live vaccines have an indirect effect on COVID immunity? Yes, it is possible. It is not at all anything I would hang my hat on. I would not change any clinical decision. It's an interesting thing to discuss, but I don't think the evidence is of nearly sufficient quality or quantity to draw any conclusions from.
I know that several dermatologists on the Derm Chat group ended up getting MMR at their hospitals or whatnot prior to it. I wanted to ask the dosage of colchicine that we would recommend, Joel, if you have that, because there are several questions on that.
So it's 0.6 milligram per tablet, and you dose it once or twice a day. But I want to underscore that there's obviously a difference between what you suspect is a biofilm and what may be transiently going on here when your immune system is revving up. This colchicine has actually been a part of the algorithms in general for delayed inflammatory reactions. So if you look at algorithms that are new, like Sue Ellen Cox just published one through an Allergan group, and Ophir Artsy from Israel has another one sort of incorporating what many people do in different protocols. Colchicine is something to consider.
Thank you. Thank you so much. I think that Dayan Thaler had just made a comment that she recently learned that non-steroidals are not immunosuppressive, not even anti-inflammatory unless given at high dose. 3 effects appear at increasing doses: antipyretic at low dose, analgesic at mid-level, and anti-inflammatory at high doses. And the anti-inflammatory is pretty weak anyway. Would you concur with that, Adam?
Let me take a look at that here. So in general, especially for what we're talking about here, I would not consider them immunosuppressive, or if they are, I would consider it to be so transient and of such a low degree that I would not be concerned. In terms of the dose-related responses, I would say that those are generally correct statements.
And a great question from Adrienne Stewart: if patient did have COVID positive test, how long are we waiting to inject fillers? She is telling her patients 3 months due to possible inflammation, etc. Thoughts?
I haven't seen any data that it actually precipitates a reaction. We call all of our patients within 2 to 4 weeks after we've injected them, and no one has reported that their filler has gotten inflamed if they happen to get COVID in that time frame. So we haven't changed our filler practice because somebody may have turned positive or they were positive a month ago.
There's another great question. We've talked about hyaluronic acids. Anything that somebody said, calcium hydroxylapatite or any other non-HAs, has it ever been reported in any of the trials or any of the patients?
Well, Renier's was Biloxol soft. So
but that's HA. Yeah, but not non-HA. So Biloxol or Radiesse or Sculptra or Alginus or any of those around the world. Anybody hear of anything?
That would be really hard to obviously determine just because of the market share that HA has. But I think this really underscores the fact that we all need to really use the MAUD database and report to it. I have an article in Press in Derm Surgery with Matt Avram and Jen Sawaya about some of the barriers that we see when we are thinking about reporting something to the MAUD database. Sometimes, as I alluded to in the patient that had the shingles vaccine, I wasn't the treating physician that placed the filler. I tried to get the records. I was unsuccessful in getting those records. So we're never going to know exactly what was placed. However, if it was our patient and we know exactly what was placed, then we should actually report these situations. That patient who had the angioedema in the Moderna trial that had that same type of reaction after the flu vaccine, that would probably be a very good idea. That patient, from what I understand, had multiple different fillers, and that seems to be the reality. And that's one of the difficult things, is that people don't have a passport of the different fillers they've had, and it could be any number of fillers causing these problems. But I think by sheer market analysis, the fact that we see these more with HA makes more sense. perhaps it's also the fact that there is HA in our own body, and that crossover antigenicity is something that we see for that reason as well.
There was a question I want to respond to in the about any opinion on delaying second dose around this. So what I would say is, personally, the way I approach vaccines, the cardinal rule, the very first rule is never miss a captive population. That is the single most important thing. So I'm going to put that out there first. The second piece is, if someone said, listen, I'm just a little freaked and I'd like to wait, then they can wait, and they should not feel like they are, blowing up the whole vaccine protocol. You never restart a vaccine series. If someone says, I'm not doing it, forget it, then I'd say, okay, I want you to get it. I think it's a great thing for you. When you're comfortable, when you're ready to get the second dose, just come in, get your second dose. There's no need for any sort of special machinations because that second dose is delayed.
I think there's one issue. So if we delay
that brings up a really important thing. I mean, they're talking now about just opening up everybody and people not getting their second doses. So Adam, you're saying that's okay?
Well,
I disagree with that.
Yeah, so I disagree with that too. It's because, again, we don't have the data for that.
Well, no. What I'm not saying it's ideal. I'm not saying that people should delay their second dose. I'm saying that if someone came to me and said, I'm not getting that second dose when I'm supposed to because I'm scared,
okay,
I might talk to them and say, well, let's talk about this. Is there something I can do to help alleviate your concerns? But I am in no way advocating for a delay of the second dose, because I want to maximize immunogenicity, maximize protection, maximize memory response as soon as possible for everyone who's up to do it. I just want to make that clear differentiation there.
And I'd like to mention Fana A had just said that they had a patient who was treated for swelling who had a calcium hydroxyapatite filler when she came in for follow-up, and she found out that she had received the vaccine a week before the filler, now wondering. So it may be due to other fillers as well. And another from Lisa Chips, we should collect data. And for a specialty, I have a colleague who had a patient who had swelling for Sculptra treated areas when she got COVID infection. Sculptra injections were 20 months prior to infection, so strange. So there's definitely the possibility of that other fillers are potentially involved.
No question. I want to say very clearly that there have been patients that have posed questions to me through text, through email, or through instant message, and I'm sure all of you that are attempting to lump all injectables together in this. And to be very clear for anybody out there, this is not something associated with botulinum toxin neuromodulators. You can set that aside. We haven't seen that with sinus infections or dental procedures, that immune stimulation we haven't seen with other vaccines, although it could potentially be possible. But that type of injection is a liquid injection, not a gel. It's not an implant. It's not a device that's there. So it's important to make that differentiation. And when people come in and they may be actually scheduled for neuromodulator and filler, I think we've all, over the past couple of weeks, added to our discussion to patients, including our consent form as well, of what happened in the Moderna trial. And there have been some other reports of it, and just explaining to them that the risk is very, very low. Some patients may decide not to do the filler and still do the neuromodulator. And I think that they need to know that the neuromodulator is very different.
And there have been several questions on use of antihistamines. Monica Rani had said for significant dermographism, she uses 2 Allegra AM, 2 Zyrtec NPM from protocol by Dr. Tharp. Any thoughts on that, Adam?
Well, obviously, in the absence of evidence, high quality, et cetera, there is some real judgment call. What I will say is there is a dose-related response for antihistamines in a variety of different situations. There's even evidence for lumping both H1 and H2 together in extreme situations. I'm not advocating that here. So I think, honestly, I don't think that there's any clear evidence that would guide me towards one thing over the other. I might be more aggressive with my dosing depending upon the patient's descriptions. and especially if there were any sort of itchiness that was being described.
Thank you. There was a question interesting in any orthopedic reports of this reaction happening to HA products used in joints.
HA fillers that orthopedics use are very different than the ones that we use. They tend to not be as cross-linked, and they don't have as many small chain HA like we use in our HA products, because they're not intended to last as 2 years or 3 years like some of our products are. So it's a bit different. And perhaps that's the reason why we don't see the similar types of reactions.
And many of those are actually still animal derived. So it's theoretically possible to probably see more immunogenicity potential with those. But the fact that it's placed so deep in a capsule means that usually people don't see it. And I think that some of the fillers that we place deep are probably not being reported as much simply because we don't see that swelling as much as we do with something that may be placed a little bit more superficial.
But Joel, don't you think we'd expect to see a little bit of pain? Like, don't you feel like even if there was a mild swelling in that joint capsule, that they would feel that sensation?
I think that's a good question. I think we should ask to the orthopedics out there.
I'm doing it right now. I'm on it. I'm asking.
My roommate from med school is a big ortho guy at USC. I'm going to text him right now.
Keep in mind, we're sort of seeing a very unusual population of subjects in this first rollout. So basically, all these subjects, or most of these subjects, are physicians or healthcare workers. And so there's a different level of potential wealth among them, also different level of usage of these products. So there may be some unique characteristics of our group that will, to some degree, disappear over time.
Well, I think these products have really become commoditized. So it's really going across a broad swath of people of different socioeconomic status that are getting filler injections. It may be interesting to see if that makes a difference in terms of the level of quality of injectable or injection or treater who was doing it. But I think one of the biggest opportunities we have now is to sort of ask these questions and establish a way of reporting, because we know that I've been talking about vaccines and changing my filler course around vaccine injections and dental work for 2 years now. So this is not new to COVID. We've all been talking about how we've seen it with other things, but there needs to be a better way for us to get information and to collect information on which fillers were used, how they were injected. The more we know, the more information we can put in. Was there pain? Was there itching? How long did it last? Was there treatment? Did it have to be dissolved? All of those things need to go into a database that's easy for either the patient, the injecting doctor, or the treating doctor to add to that database. And if we can get that out of what we're going through now, out of all these conversations we're having, I think that's going to be the best possible outcome and the best possibility for us to mitigate these reactions going forward, to better understand why they happen and maybe help them not happen.
Great. Thank you so much. I couldn't have said it better. Steve, I think you have something, and then we'll wrap it up. Thank you so much.
I think it's a great idea that Doris just brought up. If somehow there's an initiative that moves forward for better able to report on all the filler reactions, whether it's a dental procedure or COVID or vaccine, we'd all benefit from it.
Excellent. And we would love to hear your ideas, your thoughts. For all of those of you who attended, thank you so much for the over 200 people that were on during the entirety of this hour-long session. I want to thank Natasha and Meg as well for organizing all this, and all my amazing panelists. Thank you so much, Sabrina, Renier, Michael, Steve, Joel, Adam, Doris, and Siri. And I really do hope that we can use this to springboard. And then as just for those of you who are wondering, we will be having Cosmetic Surgery Forum this year again in Nashville. Natasha, you probably know the dates, which I don't, but it's in December sometime. And we are very excited to finally get back to Nashville. So
First through the 4th.
First through the 4th of December.
Thanks,
Thank you. Thank you so much, everybody. I really appreciate it.
Nashville will be open.
So Joel, I just texted 3 ortho friends, and they all said very quickly that they haven't heard of anything like this happening in ortho yet or in their literature.
Me too. That's what that's the same news that I got. And the one that they use is one that is fermented from strep, which is similar to the HAs that we use.
So I did want to point out that that the data need is very great. For instance, I have a friend at Pfizer who checked with the chief safety officer last week, and they have no reports of any issues with fillers, and clearly we're beginning to see that. So we really need to know what's happening, as Doris mentioned, and plus the denominator as well. We're seeing some numerators, but we don't really have a good understanding of how many people have been vaccinated yet.
Thank you, everybody. I appreciate it. Have a great evening and stay safe. And I hope that you all get the vaccine if you want it, and stay safe and have a great 2021. Take care.
Thank
Thanks,
you.
everybody.